It's very exciting. I'm really glad to be here. It's a great program, and I'm honored to be a part of it. So thank you for having me. The other reason I'm glad I'm here is because there's 3 foot of snow back home where so I'm going to be talking to you about MR imaging of soft tissue masses and approach to analysis. Soft tissue masses are common, sometimes because the patient presents with it, sometimes because it's found as an incidental finding, and when you see it, how should you think about it? So we know it's generally agreed that MRI is the method of choice for evaluating the extent of soft tissue masses, and you can see from these 3 images, let's see if my arrows are going to, which mouse am I using? This mouse? Okay, so you can see from these 3 images that you can see the masses quite well. You can see where they are, you can see where they aren't, you can see where they are in relation to the other anatomy. We can describe them, lobulated, heterogeneously high T2 signal masses, but can we say what they are? That's pretty hard to do here. Can we say which is benign and which is malignant? That's pretty hard to say confidently. So we biopsy these lesions, and we have both benign and benign nodular fasciitis and malignant tumors in the lower leg here. So MRI is very good for showing the extent of the lesion. It's good for preoperative or pre-treatment planning. Not as useful for characterization, but certain features can help us narrow the differential. And so these are 3 different cases where we can look at the lesion and actually make a diagnosis based on the MR appearance. So we've got a lipoma, a nerve sheath tumor, and an hemangioma. So what we're going to do today is spend a little time talking about the protocol for imaging soft tissue masses. We'll focus on what characteristics can we use to narrow the differential, and then we'll also highlight some potential pitfalls to think about when you're evaluating masses. So in terms of the protocol, I like to say that if you ask 10 different radiologists, you get 10 different protocols, but some general principles apply. Number 1, it's a good idea to have axial images because that shows you the different compartments of the anatomy and what the relation of the mass is to that, and here's the popliteal vessel. It's good to have a T1 weighted and T2 weighted image because, as you'll see, that's important signal characteristics we're going to get from that. It's useful to have a fat-saturated T1 weighted image to see where the fat is, and then also useful to have a fat-saturated T2 weighted image. You're very sensitive to small amounts of edema, and so that shows you the extent of the abnormality oftentimes. And then to complement that, it's good to have some kind of longitudinal image. In this case, I'm showing you sagittal images that are actually optimally oriented to look at the mass, to show the mass. Sometimes you get sagittal, sometimes you get coronal, sometimes you get these oblique images, but that's also useful for surgical planning because you can sort of intuitively see the relationship to other landmarks, bony landmarks or other anatomic landmarks that the surgeon can use. So we like to do that, and then it's important to give contrast in a lot of these cases, so we do pre- and post-contrast images. Ideally, you want those 2 sequences to be the exact same, with only the contrast different between them, but very important to have both pre- and post-contrast images. And then you can use your pre- and post-contrast images to generate a subtraction image, so you can be very confident what's enhancing and what's not. And many people are interested in using dynamic imaging through these masses because, as you know, perhaps from breast imaging, there are some differences in the way malignant and benign lesions will enhance, with a tendency for the rapid enhancement and high amplitude enhancement to occur in malignant masses, and lower amplitudes and shorter uptake in benign masses. Now, it's very much more reliable in breast than it is in soft tissue masses, so we can't really hang our hat on it. But as we do more of this, we're going to learn more about how to use that information. So a couple other things to talk about in terms of protocol and looking at these things. Here's a mass. We've got an axial image basically through the back of the abdomen. Here's the vertebral body. Here are the paraspinal muscles. And here's our mass and deep in the subcutaneous fat adjacent to the muscles. So how are we going to describe this in terms of our signal intensity? It's good to use an internal reference, and muscle is one of the references people use. So this mass is isointense to muscle on T1. But the thing to be careful about is if you hear or read about a mass that's isointense at T1, its appearance on a T1 weighted image and its appearance on a fat-sat T1 weighted image are going to be very different. So this is exactly the same mass. We haven't given any contrast. The only difference between these 2 images, the one on the left and the one on the right, is that we added a fat saturation pulse when we acquired the same image. If I didn't tell you that and you just looked at this image, you see that the mass is actually hyperintense to muscle, and you might think that it's enhancing. And so just don't make the assumption that the way a mass is going to look on a regular T1 weighted image is going to be the same as it's going to look on a FATSAT T1 weighted image. So that's important, and the same concept applies to T2. So here is a sagittal image through that same patient. Here is the paraspinal muscle. Here's the mass. The mass is relatively low signal, but slightly hyperintense to muscle on the T2 weighted image. And here it is on the fat-saturated T2 weighted image. So a very different story. We haven't done anything else except add a fat saturation pulse, in this case an IR saturation pulse, but the mass appears quite bright. So when you're describing the mass, it's important to compare it to a reference standard. Mostly people use muscle, but also to realize that the way it looks on the native T1 or T2 is not going to be the same as its appearance on the fat-saturated version of that same image. So I said we use gadolinium, and the main application of gadolinium in this case is not to see the mass. Masses show up very well, particularly on T2-weighted images, but to help us decide whether it's cystic or solid. And so here are two different lesions, two different axial images, both through the finger, and we have a little lobulated high signal mass here, a little high signal mass here, and my challenge to you is one of these is cystic, one of these is solid, which one is which? How are we going to answer that question? We'll give some gadolinium, and in this case you can see that there's a little thin rim of enhancement around this cystic mucus cyst in the distal finger. And then the lesion here that's actually caused a little bit of erosion of the distal phalanx enhances throughout. That's solid. That actually was a little glomus tumor. So the challenge we have here, we know we're going to see these things. Most lesions are non-specific in terms of their signal intensity, and most lesions are isointense to muscle on T1 and hyperintense on T2. And so here are two different lesions, one over here, one over here. They're both isointense to muscle on the T1 weighted images, and they're both hyperintense, in this case on fat-saturated T2 weighted images. And the answer just got given away by the MAC. This is a little ganglion cyst in the foot, and this is a synovial sarcoma in the hip. So that is the challenge that we have before us, and we're not alone in that. The American College of Radiology reports accuracy rates in terms of distinguishing benign versus malignant based on their MR appearance of 24 to 90%. Most of them are in the sort of lower or mid-range. And a representative study was performed by Ma et al., where they looked at 36 different lesions and tried to classify them as benign or malignant based on various characteristics, and they were only 58% accurate for differentiating benign versus malignant soft tissue tumors. So that's the challenge. So what can we do here? I have a few minutes to kill. Let's talk about what we can do for that. So the most important thing perhaps is to start with the clinical information. What are the demographics of the individual? Because certain diagnoses are going to be more predominant in younger people, certain diagnoses more predominant in older people, may differ from men to women. On physical exam or on history, did the mass come up quickly? Did the mass grow slowly over a period of time? On physical exam, is it freely mobile or fixed? These are all certainly relevant as you start to think about a differential diagnosis. But we're going to focus on the radiologic or MR features, such as what we see on radiographs, the subset of lesions that are bright or hyperintense on T1 weighted images, the subset of lesions that are hypointense or low signal on T2 weighted images, some special features that you can see in different lesions that are more characteristic, and then lesion location. So in terms of radiographs, this is the era of high-tech imaging, but radiographs still play a very important role. So here is a sagittal fat-saturated T2 weighted image through the foot, and you can see a little slightly lobulated high signal intensity lesion along the inferior portion of the foot. There's not that much more we can say about the diagnosis here, but we got the radiograph, and on the radiograph you can actually see that there are these little round calcifications. We've got phleboliths, so we've got a high T2 signal or fat-sat T2 signal mass, we've got phleboliths, and we know that we're looking at an hemangioma. So in that case, that was key to, the radiograph was key to the diagnosis. This is an individual who has a mass in their low pelvis, upper thigh, sitting between the femur and the inferior pubic ramus. This is a post-contrast image. It does have a little bit of this curvilinear feature here. But really, we could sit here and give a differential diagnosis, but we wouldn't get to anything too conclusive. Whoops. And we get the radiograph, and what do you see? We see ossification corresponding to that mass that's peripherally mature. And so that's telling us that we've got a mass with peripheral mature ossification. We're looking at myositis ossificans. Some people don't like that term so much and would call it heterotopic ossification, but that's what we're looking at. We're looking at a post-traumatic kind of injury, myositis ossificans. So we got pretty far with the diagnosis on that. So we're going to use radiographs. Sometimes you can look back at an old CT and get helpful information. Now let's talk about the subset of lesions that are hyperintense or bright on T1 weighted images. So there are a small group of materials, substances that give high signal on T1 weighted images. Fat, the methemoglobin stage of hemorrhage, proteinaceous fluid of a certain concentration, melanin can do it if it's there in a sufficient concentration, and of course gadolinium. And I only mention that because if you're imaging after somebody already had another study, it's worth knowing that they might have gotten gadolinium on the prior study. So usually we know that. All right, so here's an axial image through the upper thigh. Here's the femur with the cortex around it. I'm showing it to you for this lesion. Here's the subcutaneous fat. We actually saw this lesion earlier, but high signal on T1 weighted images. And how are we going to decide whether this is fat or something else? We're going to use a fat saturated image, specifically one that's done with frequency selective or chemically specific fat saturation. The entire lesion loses signal on this, and so we know that we're looking at a lipoma. So that's a wonderful, easy to read lipoma because it really is quite homogeneous without a lot of internal content. But it's worth knowing that there are a number of different kinds of fatty neoplasms that can have non-adipose content, and that is non-fatty content. So benign lipomas can have non-adipose content. They might have fat necrosis, similar to what we were just talking about. They can have fibrosis, inflammation, or myxoid change. There are also lipoma variants, specific lipoma variants like angiolipoma and myolipoma, and those can have non-fatty components. But now we start to get a little concerned because we know that you can also have a well-differentiated liposarcoma. So that's a liposarcoma, but it's still well-differentiated and it still makes a lot of fat. And Lorenz before was, so here's an example of a benign fibrolipoma, and you can see it's got some internal content different from the simple lipoma we were looking at a minute ago. But as Lorenz was saying, a lot of us look to Dr. Krinsdorf when we're reading these MRIs, and this is a nice example of, an analysis to try and help us attack this question. So they looked at 60 cases, lipomas and well-differentiated liposarcomas, and identified a number of features that favor liposarcoma. So when the lesion is large, greater than 10 centimeters, when the septae are more than 2 millimeters thick, so thickened septae, when there are globular or nodular non-fatty areas within the fatty mass, and when the lesion is comprised of less than 75% fat. And so here, in contrast, is an example of a liposarcoma sitting within the paraspinal muscles. And you can see that these are not thin, uniform septae. These are somewhat thickened. When we measured them, they were greater than 2 millimeters. And so that should start to make you be concerned. There's a more recent study by a group, Hosono et al., looking at intense enhancement of septae and nodules as another sign of a liposarcoma. All right, so lipomas and liposarcomas are not the only lesions that can be comprised of fat. And here is another lesion. We're in the arm, so we've got the radius and the ulna and the interosseous membrane. And we've got this kind of very lobulated lesion actually going into several muscles. It's high signal on T1. It's also high signal or fluid-like on T2. And if we had a radiograph, we would actually see that this round, low signal thing here turned out to be a phlebolith. So we have an hemangioma, a soft tissue hemangioma that has reactive fat overgrowth, and that's why it's high signal on T1. So another kind of lesion that can be high on T1 weighted images. Here's a sagittal T1 weighted image through the thigh and knee. Here is this high signal mass, hyperintense in relation to muscle. So is this fat or is this not? How are we going to decide? We add a fat saturation pulse, and the lesion remains bright. And in this case, it's a hematoma. And now here's one of these pitfalls we have to think about. If there were an appropriate history of trauma, that might account for it. But the thing you need to be aware of is that if you have a neoplastic soft tissue mass, it can bleed and create a hematoma, and it may present as a hematoma, but underneath it is lurking some kind of malignant mass. And so in this case, this turned out to be a synovial sarcoma. So we recommend when patients present without a truly reliable history of trauma to account for what you're seeing, that you bring them back several months later for a contrast-enhanced exam to see if there's a lesion underneath it. All right, so this is an axial image through the abdomen. This is T1 weighted. It's a gradient echo, so it looks a little bit different. But we have this lesion here that is basically isointense to the subcutaneous fat, so bright on T1. We're going to give our fat saturation pulse, and what happens? The lesion remains bright. We gave contrast and it enhanced throughout, and this was in fact a melanoma metastasis. Also, the melanin is paramagnetic and causes T1 shortening, so these lesions can be bright on T1. So if we look at that subset of lesions that are high signal on T1 weighted images, we think about fat, hemorrhage, specifically methemoglobin, proteinaceous fluid, melanin, and then again if they've already had gadolinium. And what questions are we going to ask? We're going to see, well, what is the fat suppression, what does it do on the fat suppression images, specifically chemically specific or frequency selective fat saturation? Does it lose signal like fat, or does it stay bright and make us think about our other possibilities? Also, what does the radiograph show? Is there mineralization that can help us characterize this? And then, sorry, there's your fat sat image, there's your mineralization. And then what is the enhancement pattern? Do we have a thin rim of enhancement to suggest that this is fluid, as you might see in a cyst or an abscess, a cyst with proteinaceous fluid, or does it enhance throughout to indicate that it's a soft tissue mass, a solid soft tissue mass? All right, so we've looked at the lesions that are high signal, bright on T1. Now let's talk about the subset of lesions that's low signal on T2. And there we're thinking about materials like calcification, like fibrous tissue, and the fibrous tissue can occur in a tumor like a fibroma, or as part of reactive scar, post-traumatic scar fibrosis, and then hemosiderin, which causes lower T2 signal because of its paramagnetic effects. So this was an older woman who presented with ankle pain, and here's her radiograph. Sorry, here's her T2 weighted MRI, and you can see that there are a lot of low signal masses around the joints. So, all right, we know they're low signal. They seem to be periarticular. What else might this be? So we got the radiograph. Here's the radiograph, and you can see multiple calcified tophi, and now we have a diagnosis of gout for her. So we said that fibrous tissue can also be low signal on T2. It's made up of collagen. It doesn't have a lot of free fluid, and it tends to be lower signal. So here's a lobulated, relatively low signal mass in the foot, and another low signal area in the back of the neck. And this was a plantar fibroma, and in the neck we see post-traumatic scar. And we'll talk about, later in the talk we'll be discussing location, and it's worth noting that this lesion lies in relation to the plantar fascia in the forefoot. So fibrous tissue, another kind of thing that can be low signal on T2. All right, so here we are in the knee, and sagittal images of the knee, and if you look at the T2 weighted image, there's a mass sitting at the interface of the joint, synovial surface of the joint, and kind of pooching into Hoffa's fat pad. And we looked at the radiograph. There was no calcification, but this is a great location, a great look for pigmented villonodular synovitis. It's a form of synovitis, and it's friable and it bleeds, and the end breakdown product is hemosiderin, and hemosiderin is paramagnetic and can cause this lower T2 signal. These lesions also tend to be somewhat fibrotic, which can contribute to it. But this is a nice example, if we move over to the fat-saturated T2 weighted image, that on this image, the lesion isn't so dark. So if you looked at this, you'd appreciate that subtle amount of edema that's within it, whereas it's really the T2 signal that we're focusing on for the analysis that we're trying to make. You might have heard the term blooming, that hemosiderin, because of its paramagnetic effects, can bloom on T2 star-weighted gradient echo images. So here's an axial T1 weighted image through the knee, and here's an axial T2 star weighted gradient echo image. So we're using longer TE times to allow that paramagnetic effect to evolve. And what we're saying is that anything that looks dark where the lesion is here, where the hemosiderin is here, kind of blooms. It appears physically bigger because of this T2 star weighted gradient echo technique. So that's one of the features we look for to help us identify hemosiderin. But an important take-home point on this is that not all lesions bleed enough and deposit enough hemosiderin to create the effect. And so here is the original patient we started with, and here is their mass. And there are some lower signal areas that are demonstrating that blooming effect, but you can see other areas where there's just not enough hemosiderin to cause it. So that's not, that's not the be-all or end-all. If you don't see the blooming, there may just not be enough hemosiderin there to cause it. All right, so in terms of our subset of lesions that are low or hypointense or dark on T2 weighted images, calcification, fibrous tissue, and hemosiderin. And what are the questions we're going to ask? We'll look to see if there are any calcifications on radiographs. We'll look to see if there's any of this T2 star weighted blooming effect, understanding that it's really related to how much hemosiderin has been deposited. And we'll also think about the location of a lesion. The low signal plantar fibroma we saw in association with the plantar fascia. And here is a lesion. This is a coronal fat saturated T2 weighted image through the hand. You can see the tendons along the hand. And here is a rounded low signal mass. Come back here. You can see it with the arrow. And that is a lesion, low T2 signal, fibrous lesion, or hemosiderin lesion arising off the tendon is a great look for a giant cell tumor of the tendon sheath. So location, not only where it is in the body, but where it is in relation to other kinds of anatomy. All right, so we talked about lesions that are bright on T1 weighted images, the subset of lesions that's dark on T2 weighted images, and basically everything else tends to be hyperintense on T2 weighted images. So that includes ganglion cysts, and it also includes solid lesions that mimic ganglion cysts, and it includes most sarcomas. And another really important take-home point that you may hear again and again is that fluid is not the only thing that can be bright on T2 weighted images and fat-saturated T2 weighted images. So that you really have to be aware of so that you don't miss some important masses. So these lesions that are high on T2 include both benign things like ganglion cysts, myxomas, hemangiomas, and malignant entities like synovial sarcoma, myxoid liposarcoma. So, all right, so I have an axial image through the hand. You can see a lobulated high T2 structure here, and a coronal fat-saturated T2 weighted image with a larger lobulated structure here. Cystic or solid? How are we going to answer that question? We'll give some contrast. And here you see a thin rim of enhancement around this lesion, and this was a ganglion cyst in the hand. And in this case, you see enhancement throughout the mass. So we've got a solid mass. So rim enhancement is telling us this is cystic, and I'm going to emphasize to you that you want to make a distinction between a thin rim of enhancement and a thick rim of enhancement, and then this internal enhancement telling us we've got a solid lesion. So our ganglion cyst versus a myxoid liposarcoma. So let's look at a few other lesions and see how this plays out. So I have a coronal image through the upper arm, and here is this kind of lobulated lesion that's iso-intense to muscle. It always reminds me of a caterpillar, but it's not a caterpillar. And here is a coronal fat-saturated T2 weighted image, and the lesion is relatively bright. Here you see it in axial. So we're going to give contrast to decide cystic or solid. Yeah, so much for guessing, huh? All right, so we saw internal enhancement, and this is soft tissue hemangioma. And I like to show this case because for some reason, that's the lesion that always falls off my differential. And you want to think about hemangioma before you put the needle into the lesion to biopsy it. So include that in your list of things that can be bright on T2 or fat-sat T2. All right, here's another lesion. We're up in the upper thigh. The lesion is pretty much iso-intense to muscle on T1. Hyperintense, fluid-like. If I told you this was a ganglion cyst or fluid collection, I might be able to fool you, but you would say to me, no, we're going to give contrast to decide because that's not a great location, a typical location for a ganglion cyst. So we give the contrast, and although we see a thin rim of enhancement showing us that much of this lesion is cystic, there's a more solid nodular component that enhances, and this was an intramuscular myxoma. So still a benign lesion, but certainly important to give the contrast and decide whether there's a solid component, and certainly. All right, so what about this? We're in the distal thigh, we're posterior. Here is the lesion. This is actually the marker, so this was a palpable abnormality, pretty isointense to muscle with a little bit of a mass effect. Axial image through the same lesion right here, hyperintense on T2, maybe a little subtle internal signal, but really pretty bright. The surface of it is smooth, but actually this was a myxoid liposarcoma. So this was a pretty bad actor, a myxoid liposarcoma. You don't want to walk by that. We certainly gave contrast, so here's the pre-contrast image, here's the post-contrast image. It enhances throughout, it's solid, it went on to be biopsied and treated appropriately. So in terms of lesions that are high signal on T2, although ganglion cysts are common, we see a lot of them, fluid, it can be that. You have to remember that solid lesions can mimic cysts, and certainly sarcomas can mimic cysts in that respect. So you want to look at the enhancement pattern. Is it a thin rim of enhancement, or is it internal enhancement, showing you that there's a solid component? And then is the rim thin or thick? To call something a simple cyst or a simple ganglion cyst, you want to see a thin rim. If it's thicker, you have to think about the possibility of inflammation, some kind of inflammation. Even ganglion cysts can become inflamed, or an abscess, or a necrotic high T2 tumor. So those are the kind of questions we're going to ask there. Now, there are some special features that you can look at to help you tease out what different lesions are, and I don't have a full complement here, but I wanted to show you some nice representative ones. For some reason, nerve sheath tumors have won the lottery in terms of signs. We talk about the target sign, the tail sign, and the split fat sign as signs of peripheral nerve sheath tumors, and then lipomatosis of the nerve, which is really what we would call an at-mini, which is something that you recognize the minute you see it. So here's just an example of a target sign for a nerve sheath tumor, axial T2 weighted image, and the outer periphery is more myxoid in content and is brighter on T2. The central portion is more collagenous and is lower signal on T2, right there. And it took me a long time to remember how this worked, but it's the opposite of necrosis, right? Necrosis would be bright in the middle and dark on the periphery on T2 weighted images. The target sign for a nerve sheath tumor is bright on the outside and lower signal internally. And then here's just the tail sign is the thickened nerve coming into the nerve sheath tumor, and here we see it in the knee, and here is thickened nerve going in and going out of the nerve sheath tumor in the wrist. The split fat sign is simply this idea that the lesion kind of parts the muscle around it and has some surrounding of fat, so it's splitting the fat. And then this is a case that will show us something interesting. Okay, so axial T1 weighted images through the lower legs in a patient. So this is the normal side. You can see the posterior tibial nerve over here, and here is the abnormal side. We see individual nerve fascicles with a lot of fat separating them apart, and this is lipomatosis of nerve. And this is kind of, once you've seen it, if you ever see it again, you'll have a good idea of what you're looking at. Here is the fat saturated image, and the fat saturates, so we know it's fat, and the nerve fascicles are seen in between that, and as you see, they're a little brighter than they were on the T1 weighted image because we've added a fat sap pulse and changed the dynamic range of the image. But basically, if you keep that in mind and you ever see it again, you'll have a good idea that you're looking at lipomatosis of the nerve. So location, again, we can't show everything possible, but here's an axial post-contrast image through the upper chest, and we see these enhancing lesions deep to the scapula, and that's a very characteristic location for an entity called elastofibroma dorsi. It's often bilateral, but not exclusively bilateral, but if you see a mass in that location, you certainly want to think about the possibility of this benign entity. And then in this case, we're looking at a sagittal T2 weighted image in the lower pelvis. We have this large lodulated mass. You can see urine in the bladder, bright on T2. Here's the pubic bone in front. And this lesion is centered at the perineum. High signal on T2. We need to give some CAD to decide, we need to give some contrast to decide cystic versus solid, and we do, and it enhances, and this is an aggressive angiomyxoma. Very characteristic location for an aggressive angiomyxoma to be centered at the perineum like that. It can occur in other location, but the overwhelming majority in this location. All right, here's a young man who presented with a mass just above his elbow. So on the axial image, you see his humerus, and here's the mass. We gave contrast, it enhanced. There's no fatty hilum here, but that's a great location for what? an epitrochlear node, and in this case the node was involved with sarcoid, and so it effaced the fatty hilum, but thinking about the location helped us realize that we were probably looking at a process. You can see this in cat scratch disease. It can become involved in other inflammatory neoplastic processes, but it's important to think about that as a location that's typical for a node. All right, so we said location is sometimes anatomic and it's sometimes structure. So here's an axial T1 weighted image through the wrist. Here's the radius, here's the ulna, here's the marker, and the marker around the palpable abnormality. There is the palpable abnormality. Here it is on the T2 weighted, fat saturated T2 weighted images. They asked you to biopsy it. Did you say yes or no? You said, well, wait a minute here. There's a lot of pulsation artifact off this thing, and by the way, it connects to the radial artery, so no thank you, I'll pass. This was a radial artery aneurysm. So again, thinking about where things are. So 3 important pitfalls to talk about. Malignancy can appear non-aggressive. So we've seen a couple lesions now that were sarcomas, but they're not very aggressive looking. They can be small, they can have very smooth borders. Soft tissue sarcomas tend to have smooth borders much of the time. And so they can appear non-aggressive, but don't be fooled by that. So in this case, this lesion was a small synovial sarcoma. As we said before, not everything that is bright on fat-saturated T2 weighted image is fluid, and this was another myxoid liposarcoma. Very bright on the T2 weighted images because of its myxoid content, but obviously enhancing because it's got solid components. And then we said that when you see a hematoma and it's not clearly explained by trauma, you have to think about the fact that it's a hematoma that's arisen around an underlying mass, and you want to do pre and post contrast imaging to see if you can, and subtract it to see if you can pick out an enhancing component that you would want to biopsy, and if not, you may need to follow it just to see that it resolves and there's no underlying lesion. All right, so I can't really do justice to the thoughts about biopsying these things, but at some point you can characterize the mass on MR or other imaging and you need to go to biopsy, but there's concern about seeding malignant cells along the biopsy tract. And one of the worst things you can do is choose the wrong biopsy tract so that it necessitates a much more extensive surgery. You really don't want to violate a compartment that's uninvolved. And so it's very important to consult with the surgeon who's going to be doing the definitive surgery, because they make an effort to excise the biopsy tract at the time of limb-sparing surgery. And Mencken did a study that showed in a not insignificant percentage of cases, problems with the biopsy caused them to change to a much more extensive surgery, and in some cases actually led to an unnecessary amputation. So if you see a mass like this and somebody asks you to biopsy it, find out who's going to be doing managing the surgical part of that and work with them to pick the appropriate biopsy tract. So in conclusion, MR is the preferred modality for evaluating soft tissue tumors, and as we saw, it's the method of choice for determining the extent of the tumor. Excuse me, but it does have limited accuracy for characterization, and biopsy is often required. But certain features can aid in characterization. So the presence of some kind of characteristic mineralization on radiographs or CT, the subset of lesions that are bright or hyperintense on T1 weighted images, the subset of lesions that are low signal on T2 weighted images, the location can be helpful, and certain characteristic features can help us sort out what we're looking at. So here's calcification and nodular fasciitis, another form of intramuscular soft tissue hemangioma, the giant cell tumor adherent to the tendon we were seeing before, another little plantar fibroma associated with the plantar fascia, and another case of lipomatosis of the nerve here in the ulnar nerve. Great, thank you very much.